Welcome to Lecture 2, in which we will be looking at ways to compare two groups in a study. Last week we discussed basic research principles and got some practice using the PICO method. This lecture will focus on methods of comparing outcomes between the two groups, that is, the intervention and control groups, in a given study population. By the end of this lecture, you should be able to describe the need for comparator groups in medical research, interpret correlations between variables, calculate basic epidemiological statistics, including incidence and prevalence, and calculate and interpret comparative statistics, including relative risk and odds ratio. Let's start with a case study which demonstrates the need for comparator groups. You're working in a drug information center in a hospital. A medical resident calls you and tells you that he has a clinical question. One of his patients is being treated for pancreatitis and has continuing abdominal pain. The patient's on a medication called pancrelipase, and the resident wants to know if this is the cause of the abdominal pain. So you look in your drug information database and you find the following information listed. Under adverse drug reactions to this medication, there is reports of abdominal pain 3% to 18%. So based off of this information, what should you tell the physician? What further information do you need to make an informed decision? This is a very common occurrence, and I want you to ponder your response as we talk through the rest of the lecture. Medical history is full of examples about treatment options that have no substantial evidence regarding their efficacy. For example, in the 1800s, practices such as the use of mercury ointments for syphilis, the use of bloodletting, which involved removing blood up to the point of a patient passing out, and the use of purgatives for many conditions. These practices were based on years of tradition and no experimental or comparative research. When research was actually conducted, it was found that these treatments often caused harm when compared to no treatment. This continued into the 20th century with the widespread sale of snake oil as a cure for pretty much any medical disease. In one remarkable study, Clark Stanley, known as the Rattlesnake King, would sell snake oil for a diverse array of conditions. However, it was discovered that the bottles actually contained mineral oil and had no therapeutic benefit. He was fined $20 by the newly formed FDA. Following the passing of numerous FDA regulations, we now require efficacy studies before prescription drugs are approved. However, in other fields, efficacy studies are not needed. These include homeopathy, crystal healing, and complementary medicine. If you only look at the percentages for resolution with treatment, it may cause you to misjudge its actual efficacy. So, for instance, if a 16th century mercury salesman presented to your apothecary, they might tell you that they had the best bloodletting treatment regimen in town. In fact, their phlebotomy utensils resolve diarrhea in a stunning of 75% of cases. Not only that, but severe dehydration results in only 30% of treated patients. Would you recommend and stock this bloodletting regimen? So here are those numbers again. Looking at efficacy against a comparator group, for instance, placebo, you can make a more objective decision. So in this case, in cases where there's no treatment for traveler's diarrhea, you would see diarrhea resolution in 80% and severe dehydration in only 15%. So looked at this way, a comparator group can show you the difference between a cure and a detriment. Without comparator groups, clinicians may jump to inappropriate conclusions. Let's take the extreme example of looking at a quote from the famous Roman physician Galen. "All who drink of this treatment recover in a short time, except those whom it does not help, who all die. It is obvious, therefore, that it fails only in incurable cases." Although this example appears extreme, it's easier than we think to jump to false conclusions if we don't actively remind ourselves that we need a comparison group. Natural history and regression to the mean are two of the three primary reasons why we may jump to false conclusions without comparison groups. Natural history refers to the natural course of disease without the use of any intervention or treatment. For example, we know that many diseases will improve without medications, such as the common cold. Yet many people demand antibiotics from their doctors for this condition and swear that they work, even though the vast majority of cases are due to viral infections. in which case antibiotics provide no benefit but may cause potential harm. However, by using a comparison group, we could conduct a study to show antibiotics are ineffective treatments in the majority of cases, even though a patient or provider's perception may be different. Comparator groups also control for regression to the mean. Regression to the mean is a statistical phenomena in which outlying or extreme values naturally tend to normalize over time. This is true when looking at variables which are subject to randomness. For example, extremely tall parents tend to have children who are also tall but not quite as tall. This is also true for diseases. If you have a disease such as chronic back pain, which fluctuates on a daily basis, you may attribute your symptoms to whatever treatment you took on the day your pain was the worst. For example, you may recommend a patient take ibuprofen for her inflammation, but the next day she may have horrible pain simply by chance, so she may go to an herbalist and have a dandelion tincture. The next day her pain may subside due to regression to the mean. However, she may attribute the improvement to the herbs. By using a control group with a large number of patients, we can have a better assessment of what is actually happening and help the patient and what is not. As a last example, look at the random variation in 30-day hospital readmission rates from Beaumont. As a pharmacist, it is your job to reduce these rates. However, if you don't use a control group, you will never be able to tell if you're helping or hurting patients because there is so much natural fluctuation. Finally, control groups can help us control for the placebo effect. The placebo effect is an improvement in a patient's clinical condition related to the expectation of treatment. If patients naturally feel better when they take tablets, then we will never know if their improvement is related to the treatment or the placebo effect. Take a look at this example from studies on depressed patients. The blue bars are patients who receive antidepressants, and orange bars are for the patients who receive placebo. On the right-hand side of each comparison, we see that there's no difference in efficacy between placebo and medication. However, on the left-hand sides, we see that people who have had past exposure to antidepressant medications actually do feel more relief. Why? Because they recognize the effects of the medication on their bodies, and when they do not have that effect anymore, they assume the medication is not working and the placebo effect is lost. So how do we eliminate the placebo effect? We should use a comparator group to ensure that medications are actually effective compared to placebo alone. If they're not, then we shouldn't be recommending them. Also, blinding investigators and patients makes sure that the two groups truly remain equal. What's the takeaway from this lecture? You cannot reliably assess the efficacy of therapy without a control group, so always look for one. Control groups can be placebo, but only if no reliable alternatives already exist. If you're reading about a new blood pressure medication, the investigator should compare it to a medication we already use. Because if we don't care if the new medication is better than nothing, we want to know if it's as good or better than the best medication we already have. In cases where treatments already exist, we should use active treatment in the comparator group. Let's return once more to our question from the medical resident who asked, is pancrealipase causing my patient abdominal pain? If we looked elsewhere and found that the rate of abdominal pain in a placebo group, for instance here, is 35%, we can see that pancrealipase actually significantly reduces the rate of abdominal pain in patients with pancreatitis. Knowing a comparator group can completely change your perception. You need one to make an informed decision.